Hey guys, my name is Allison. I am a respiratory therapist in Utah. Um, I mostly work at the University of Utah, and I also am an adjunct instructor at Weber State University. This is a theory and equipment management lecture for the high frequency oscillatory ventilator that is most commonly used in the newborn ICU for preterm infants. So the first part of this lecture, we will talk about theory, ranges, settings, how we would change something, why we would change something. If you get a blood gas, what would you change? And then the second half of this lecture will be to discuss equipment management, certain things to change, maybe troubleshooting experiences such as that. Since I am just going through this lecture, I have my little cursor here to point at things, so sorry that it's not more technical. Okay, high frequency oscillatory ventilation. What is it? Throughout the lecture, you might just see me on this presentation have HFOV. But this is a special strategy of ventilation that uses small tidal volumes, typically less than 1 ml per kilogram, at excessively high rates to allow for lung protective ventilation, commonly for neonates with respiratory distress syndrome and other compliant pulmonary factors. That's a mouthful. So essentially we are using extremely high rates and very, very tiny tidal volumes to keep the lungs open and ventilated to allow for lung protection, minimal stretch, and appropriate gas exchange. The kind of story goes that the development of the oscillator happened with a physiologist that was watching their dog on a hot summer day pant and was just thinking to themselves, my dog's over there just breathing like crazy, breathing 100, 200, if not more times a minute over there, panting like a gross dog, like the one next to me. But gas exchange must be happening. Like, how is gas exchange happening when a dog pants at such a high rate? And that's when they began to do theories and tests to test for opening up the airways so that we can decrease surface tension, open up for oxygenation purposes. Because remember, gas exchange and appropriate oxygenation and ventilation occurs when we do have appropriate surface tension with appropriate pressure applied to it. And then little tiny tidal volumes to help prevent any pulmonary damage, barotrauma or volume trauma that might come from excessively stretching that really decreased compliant tissue. So this is the ventilator I'm discussing. This is one that was actually on a patient. Another old story that you might find interesting is when this was first developed, we have specialty diaphragms now and pistons to help with ventilation, but they first used old World War II pistons from the war when they were first discovering it, because they're like, well, these pistons worked just fine. Now it's a little bit nicer. We've upgraded. We'll talk a little bit more on where things are with equipment management near the end, but I wanted to show you the ventilator we're discussing. I think a lot of people get intimidated because this is a very different looking ventilator. It looks blocky. It looks kind of like something from the 1980s. But once you break it down, it is a very effective form of ventilation, very beneficial for newborns with premature lungs. And really, you're just adjusting a couple knobs, even though it looks like something from the 1980s. So we'll break it down in a little bit. Okay, so when is it used? When is it indicated? Because sometimes that's a question of when do I use this? When do we put it on a baby? It is a common form of ventilation in the NICU and with neonatal populations. It is, I like to call it powerful but protective. If you want power, if you have very stiff, hard to ventilate lungs, the oscillator is the knee-jerk reaction to go to. It works fast, it works quickly. It's very good to help open up those de-recruited lungs, to get down and use additional power and pressure to really open up and to get those alveoli doing what they need to do. So some indications down here, you can see we have prematurity, respiratory distress syndrome, which commonly go hand in hand. So respiratory distress syndrome in neonates typically is a lack or dysfunction of the surfactant within the lungs. Oftentimes we replace that surfactant. But respiratory distress syndrome is essentially all those little alveoli are sticking together, and we want to make sure they open up so the alveoli don't stick together until they heal, or we get surfactant either replenished or replaced to help decrease surface tension, because that's what causes barotrauma and volume trauma, is that excessive opening and closing and those alveoli sticking together and rubbing together. I like to think of it as either like clapping, how you clap your hands. Let's say you have honey on those hands, it would be sticky to pull those hands apart, as opposed to if you had something slippery like soap on your hands. Because we sometimes like to think of surfactant as it's a way to decrease surface tension in the alveoli, similar to how soap helps decrease surface tension. Another example for RDS and why we would use it, an oscillator and surfactant replacement, is think of like if you have two frozen steaks that are stuck together and you try to rip them apart, and it takes that effort to rip them apart, and we cause that hyaline damage from those tissues sticking together and ripping apart. That's similar to respiratory distress syndrome. And infant respiratory distress syndrome is those alveoli stick together like those two frozen steaks, and you're pulling them apart, and that causes that hyaline damage, which causes damage to the lungs. So we're trying to prevent that and help keep the lungs open, to prevent them from closing together, to help keep the integrity of those lungs. Congenital diaphragmatic hernia. This is also an indication because we need those higher pressures and oscillation to help open up those lungs and to move past the pressure that is happening outside of the lungs from the guts in the chest, we'll say. So those guts in the chest move on up due to a malformed diaphragm, and the oscillator is really good about using that additional pressure to help open and stent open the lungs to move past the pressure coming from the misplaced organs from the abdomen. Pulmonary hemorrhage. This is my go-to the oscillator is my go-to if there is any indication of pulmonary hemorrhage. And that's because it is lung protective. It's very gentle on the alveoli, but also the higher pressures, I like to give a higher mean airway pressure to help stent that bleeding and make sure that bleeding doesn't continue. That basically, like putting your hand over a wound, is essentially what we're trying to do. We're trying to tamponade or just hold additional pressure against that bleed to help stop it from bleeding. And that's why we would use it for pulmonary hemorrhage. Abdominal anomalies. So the oscillator is very good, just like with congenital diaphragmatic hernia, of moving against that additional abdominal pressure. One time I had a baby that during pregnancy, mom was infected with CMV, and the baby had liver issues and came out with ascites. We actually took a liter of fluid we tapped, and I had probably the highest pressures I've ever had on an oscillator on this baby. But then as we relieved and tapped that stomach, I was dropping those pressures like crazy. And that's why we chose the oscillator, because not only was I able to protect the lungs in a way, but also I had that pressure to keep the lungs as open as I could to help ventilate and oxygenate that baby while we relieved the abdominal issues. And any restrictive complications, this is my go-to if I have a kid that, again, prematurity, if I have a super, super little. Also, if I do get a kid that just isn't doing well, maybe there are complications, low APGAR scores, needs bagging. If I'm getting a fresh kid that we're coding, I like the oscillator because it is such a solid piece of equipment that does a lot of good for the lungs. Okay, so what do I even set? So with all those buttons and knobs that we have, let's just break it down into, I'm all about the keep it simple life. So if we need to adjust ventilation, we adjust the amplitude and the hertz. If we need to adjust oxygenation, mean airway pressure, and FiO2. Just keep it separate. Think, okay, I'm having an oxygenation issue. What do I need to adjust? Mean airway pressure. Okay, or I need to go up on my FiO2. If I'm having a ventilation issue, what do I need to go up on? Do I need to go up on my amplitude or do I need to go up on my hertz? Because they're what's affecting my ventilation. And we'll get into when you would change what and why. So amplitude. I like to think of amplitude as the size or of each individual breath. So each of the little tiny breaths we're giving at several hundred times a minute, this is how big we go. You can also go back to like 7th grade science class, but honestly, who wants to go back to 7th grade? That was junior high. It was dark times, everybody, for everybody. Don't tell me it was the best time of your life. It's dark for all of us. So amplitude, it's similar theories to things such as sound. So the size of each individual breath is the amplitude. Think of it as mini tidal volume, little itty bitty tiny baby tidal volumes. We use the power knob, and I have pictures coming up to show you the power knob. So we drive the size of the amplitude by adjusting by power, and it's an actual measurement on a knob we use. This helps to alter the bounce. So if you're looking at your baby and there will be actual chest bounce, the ideal is down to the umbilicus. Sometimes we have too much amplitude and you're like, oh, I'm going to bounce my kid off the bed. Like they're bouncing like crazy. And other times you're like, I don't have a ton of bounce. Like, are we not ventilating? Are we just that stiff? That's part of the problem solving, is figuring out your bounce, and you can adjust your amplitude with that. When it comes to blood gas changes, whether it be arterial, venous, or capillary, I like to think of adjusting my amplitude as they're my little bites to change my CO2. They're what I would change if my CO2 was just a little bit off and I'm just trying to find our happy place on the ventilator. If maybe my CO2 is just like 5 or so away from where I want it to be, either hyper or hypoventilated, I would adjust my amplitude. I like to think of it as my little bites of adjustment. So settings. And again, these are general settings. These are a pretty safe area to start at. So, but I will be the first to say you can go out of range. There's no such thing as normal, strict, specific things for every single patient. So make sure you assess and take care of each individual patient. But these are pretty safe ranges you can start out in. So our amplitude range, typically between 10 and 30 centimeters of water pressure. Everything when it comes to pressure on the oscillator is directly measured. Remember that when we are talking about mean airway pressure. These are direct centimeter water pressure measurements. My favorite is I like to start at an amplitude of 20, but I like to start in the middle and I go up and down as I need to. So 10 to 30 centimeters water pressure is a great place to start. Depending on pathology, you might go up or down a little bit depending on what's going on with the baby. But I like 20. It's a safe number. It's right down the middle. You can adjust where you need it to be. Again, amplitude is driven by a power setting on our little dial. Side note, it's actually a really fun dial to turn. It's mine. If we have high CO2s and we want to decrease our CO2, we will increase the amplitude. If we have low CO2s, like maybe you overshot or we have sudden increase of compliance or something like that, and we need to help raise our CO2, we will decrease the amplitude. So again, think of it as your mini tidal volume. Okay, so I'm not ventilating, so I need to increase my tidal volume. So I would increase my amplitude to blow off more CO2. Vice versa. Okay, I'm blowing off too much CO2. I need to decrease my tidal volume. So that way I would decrease my amplitude. All right, here's some pictures. Here is a visual of amplitude. I am sorry, I am kind of a bargain basement lecturer, and I drew you pictures. So you can see we have our mean airway pressure right along here. And then we have, some people refer to it as a delta P. All that is saying it's a change in pressure. It's the difference in the pressure between your amplitude and your mean airway pressure. So if you hear people say, oh, the delta P is this, they're just subtracting the amplitude measurement from the mean airway pressure to give that little breath. Everything underneath each little hump is CO2 that you're ventilating and releasing. So each of these little breaths, little tiny breaths, is a little bit of CO2 that is being exhaled. So you can think of it as the size of each individual, you might hear called a cycle or a tidal volume, either way. Again, our little bites. Up the amps to decrease CO2, decrease the amps to increase CO2. Over here you can see here was our first current amp. And let's say we needed to blow off more CO2. We would increase the size, add more, either be 1 or 2, to have larger individual cycles or breaths to blow off more CO2. See how this is smaller than this? That's what we're doing with amplitude. One thing specific to the oscillator is it has active exhalation. That piston goes back and forth to provide ventilation. So that's why we go down below, airway pressure, so that we can ventilate and get down there. And that's just part of how it's a more power-based machine. Over here you can see this is where the setting will be. Amplitude, again measured in centimeters of water pressure. And then our power button. So it's a little dial, and you can lock it. I always lock it after, just not for any sketchy reason, but just so that I know my settings are solid. And also, the most common time it's going to get bumped is when you're wiping off your equipment and cleaning it. And then you're like, oh, oops, I accidentally turned my knob. It happens. So you'll unlock it. This little black piece goes up. And then to the right is to turn the amplitude up. To the left is to turn it down. And then when you are charting, you would see there's a number in this little window right here. And then these. So I would chart my power as maybe 1.4 or 1.5. It's right in the middle, so take your pick. That is my power that I'm using to drive my amplitude. So that is amplitude. And then I just lock it again. This is just a specific thing I like to, a lot of the RTs I work with, including myself, like to do is sometimes, depending on what's going on, sometimes even if the kid's just breathing on their own, the oscillator has a tendency to kind of wander on your pressures and settings. So I like to write it here, so if it starts to wander, it will match up. Okay, hertz, the second part of ventilation. So hertz, I like to think of as it's kind of like a pseudo-respiratory rate. It's the frequency, so frequency just as with a respiratory rate, it's how frequently it happens. Each individual cycle is delivered. This particular oscillator, the manufacturer has hertz range from 6 to 15 hertz. And each hertz is 60 cycles or breaths. Again, I like to start around the middle. I like to start at a hertz of 10 and then go up or down as needed. So 10 times 60 cycles would be 600 breaths. And you can see we have a little math equation down here. So whatever my hertz was times 60 is our total frequency. 10 hertz times 60, 600 cycles per minute. Or you could call it breaths per minute, whatever you prefer. I like to think of hertz as my big bytes, which we will talk about in the next slide. So hertz management. Hertz are used to manage ventilation. It is opposite of conventional ventilation for CO2 management. So this is where it's like kind of tricky. And even though I'm super comfortable with this vent, sometimes I still have to like kind of think about it because it's backwards. So to decrease our CO2, we decrease the hertz, where normally we'd be like, wait, don't we need to increase the rate or the frequency in order to decrease CO2? Nope, it's opposite, and I will show you why. Same with CO2. Okay, I need to increase my CO2, so I'll increase my hertz. So this one is direct. Okay, I need to drop my CO2, I drop my hertz. I need to increase my CO2, I increase my hertz. I like to think of, with my blood gases, the big bytes. These are big bytes to change your CO2. So this would be if I have a CO2 extremely out of range, either one way or another, whether it be maybe I'm hypoventilating and my CO2 is in the 90s. I'm like, oh crap, I need to make changes. Or opposite, maybe I have a CO2 in the low 30s. Oh crap, I need to make changes. That's not where I want my blood gas to be. Because remember, by changing 1 hertz, you change the rate or cycles by 60 breaths per minute. And that's why it ends up being the big bytes. So here you can see we have a hertz example here. We have our mean airway pressure, and we have the amplitude that is set and is being reached. 1 cycle, so returning back, is that is 1 cycle. So that's 1 frequency, you could say. So 1 hertz equals 60 cycles or breaths in 1 minute. And then again, we have our little equation here. And then we increase our hertz to increase our CO2. We decrease our hertz to decrease CO2. Because it is the 60 cycles, it's the big bytes. And here's a visual representation of why we do that. So again, everything under each little camel hump, or whatever you want to call it, is CO2 we are exhaling. If we increase the hertz, we make each breath smaller. See how these are more narrow down here than they are up here? We're making each little cycle tinier and skinnier, which gives less CO2 that we're exhaling, which will help increase the CO2. Meanwhile, over here, we are decreasing the hertz. See how it makes for a wider and larger, say this is the same amplitude. They're matching, same mean airway pressure, matching. But these are tiny breaths. So we're doing less CO2 each individual breath. Whereas if we drop the hertz, they happen less frequently. The hertz happen less frequently, and we blow off more CO2 because there's more CO2 in this breath than in these individual breaths. In this bottom corner, bottom down here, is where hertz are. You just adjust it with the knob. And this one doesn't wander as much as the others. It stays pretty solid where it needs to be. So that's where this particular event we have set at 9, and you can see frequency and hertz. And you just turn it where it needs to be. Mean airway pressure. So this is the average pressure maintaining the lungs to aid in alveolar recruitment. So I also like to, this is the pressure above PEEP. So we have our PEEP and our PIP. This is the average pressure in the lungs. This is the average pressure we're trying to open up and maintain our lungs open. This is what we use for oxygenation purposes and recruitment, because we're trying to open up, trying to get things so that they're ventilated, so we can, not ventilated, get things oxygenated, because oxygenation and gas exchange happens with appropriate pressures at an appropriate surface area. When it comes to equipment, we adjust both the bias flow and the green knob adjustment. You guys will see. The tricky part with mean airway pressure is you need to it's kind of a balancing act at times. So we need to be able to provide appropriate oxygenation, proper lung expansion. We want typically around 9-ish ribs expanded on an x-ray, but sometimes you might need to go up still if we're totally whited out on an x-ray. And then also you want to make sure you're not giving so much that we're causing blood pressure issues, maybe on a very, very unstable child, and we're not decreasing venous return, just as with any other baseline or average pressure, such as with PEEP. Same considerations, you just look for the optimal. And then this is the pressure that maintains and supports oxygenation and alveolar recruitment. Dope. Mean ranges are 8 to 16. 8's the lowest I feel comfortable going on an oscillator. Again, I like to start at 10. 10's a pretty safe bet. And if you think about it with conventional ventilation, mean airway pressure of around 10 for some sick lungs, yeah, that makes sense. That's about where mean airway pressures, even with conventional ventilation, occurs. So 10 is a good place to start, unless you have other considerations you're worried about. So you can use, there is a bias flow setting. This is between 10 to 20. Again, I am all about going in the middle and adjusting up and down as I need. I like to have my bias flow around 15 when I'm calibrating my oscillator and the circuit. Okay, let's say we are moving from conventional to a high frequency oscillator. The mean airway pressure should be 2 to 4 centimeters water pressure above the PEEP. Okay, so let's say we have a PEEP of 7. Your mean airway pressure would typically be 9 to 11. So yeah, I'd start at 10, right in the middle there. Other times you might consider increasing mean airway pressure is to increase your FiO2. So if our FiO2 is climbing consistently, not just like how that happens with cares, procedures, anything like that. If you have a baby that is just quiet and just hanging out in bed, and your FiO2 is increasing and increasing and increasing, and you can't get it down, you might need more additional pressure. I like to go by the 20% rule. If, let's say, I start my shift and my baby's on 40% FiO2 and I go up to 60% FiO2 and we're consistently hanging out there, I want additional pressure, because clearly we don't have enough pressure to allow for accurate gas exchange. So with a chest x-ray, ideally 9 to 10 ribs expanded with a curved diaphragm and appropriate aeration is the ideal. But since when do we ever deal with the ideal? But that's your goal you're aiming towards. So mean airway pressure. So while our ventilation's doing their thing with their amps and their hertz, we have the average pressure maintaining the lungs open. These are little lungies. So we would increase our mean airway pressure to increase oxygenation. So down here, let's say this line right here was our previous mean airway pressure. We increased that mean airway pressure right here to allow for more expansion in the lungs, to allow for improved oxygenation. So when we increase mean airway pressure, we increase pressure, surface area, and it is our attempt to decrease VQ mismatch by improving the alveolar for the V part of VQ mismatch, so that we don't have little collapsed alveoli. And the way we're decreasing BQ mismatch is, here's our little alveoli that are being oscillated. See how this one is a little bit collapsed, not doing so good. We increase our mean airway pressure, and all of a sudden we are well recruited. We're allowing proper ventilation. We're working appropriately. So this is our little alveoli diagram of what happens when we increase mean airway pressure. So again, centimeters of water pressure. So be careful. Just keep it in the back of your mind when you're making adjustments, either to mean airway pressure or amplitude. Both are in centimeters of water pressure. See, mine has wandered a little bit on this ventilator. I would just adjust that back to match the 10 that I have set here. This one thing that's kind of tricky is this setting is in the far left, and you adjust these settings based on the far right. So here we have our bias flow, and you can see the little marble thingy here is set at 15 liters per minute, and you can adjust that up and down. This is how we adjust the bias flow. You can go up or down, and this is a little sensitive, so you're not going to be going crazy everywhere. So we decrease it to the left, we increase it to the right. This is our limit. Essentially, it's kind of like the Pmax on a Draeger or a pop-off. We just set it to allow for, if for some reason our pressure keeps climbing, whether it be an equipment malfunction or something's going on with the baby, it will limit the pressure as it continues to climb. If for some reason your knob and your limit are kind of getting close and they're adjusting, they're getting close to each other, you might have to perform what's called a dump, which is you increase your bias flow a little bit so that you can decrease this so that they're not in the same position. FiO2, you all know how to titrate FiO2, and you all know what it is. It is the percentage of oxygen being delivered to a patient from the ventilator. We have an actual blender attached and is delivering the pressure and flow we need to the oscillator. And again, 21 to 100% can be given. So here is our actual blender attached so that you can change the percentage of what your baby needs. Here is our air and oxygen hoses in the back that are coming from the wall at 50 psi. And then we have a valve exhalation right here, which allows for if we are having increased pressures in this blender, and then out to the ventilator to actually pressurize the ventilator. Hey, to adjust it, to make sure we're giving accurate and appropriate, we use an oxygen analyzer. The only time we'll take this out is if we put nitric in and there's an analyzer in the inhaled nitric setup. But the oxygen analyzer, you just use a T-piece, an open T-piece, on the dry side of the heater. So you can see we have a concha heater here with our little box of water feeding in. This is the gas line, the dry air gas line going in, and then we have our analyzer right here. You typically want to analyze this about every shift just to make sure that we have accurate readings of FiO2. And then it comes up to your analyzer to make sure that we're giving appropriate oxygen titration. Okay, we're going to talk equipment management. You want to try to keep the circuit in a neutral and laminar position to give the best ventilation. The most comfortable way to do this is a two-person method. Have one person watch the tube, because if you flip the tube from one side of the head to the other to help prevent any type of breakdown or anything, it's best practice to have one person watch the baby's airway while the other moves the oscillator back and forth to provide for laminar flow. It is a heavy circuit, so make sure that the ET tube is not being pulled or torqued. It's very easy to do because this is such a heavy circuit. So just make sure everything is in a nice position and lock the wheels. Lock the wheels. Lock the wheels. Lock the wheels. The only time I've ever had horns come out on my cute, sweet L&D nurses was one of them was bringing a mom in, and she grabbed my oscillator and she went to just shove it. And it was at the beginning of my shift, and my claws came out, and I told her, "You never touch that piece of equipment, because lock your wheels, people. That is a surefire way to get your baby extubated, and that's not good." For accurate flows, you'll need to remove the condensation from the circuit. It is just inevitable. It's part of it. You can just get a napkin and tilt it up, and I'll show you where that condensation will remove from. Make sure that your equipment is properly calibrated, and you go through the calibration steps. I have a video on how to calibrate the circuit in my YouTube channel if you guys want to look that up. I'm not going to get into it on this lecture, but make sure that it is appropriately calibrated so that you're giving accurate ventilation and oxygenation to your baby. The other thing is check the piston is centered. The easiest way I like to do it is, I'll show you where the start-stop button is. I like to just pause my oscillation, press my start-stop button, and then that is the easiest way to make sure your piston is centered, because then the oscillation isn't holding and you can see where your piston is located. I will show that to you. So these are control and monitoring lines. They all come out to and from the oscillator to these little diaphragm discs that measure so that we get continuous feedback. So we have the control, which is our mean airway pressure, our dump, which is what is our limit, so that we limit airway pressure. This is to get accurate readings to make sure that the patient and the vent are in synchrony. And then a limit, which again helps measure for alarm purposes that our mean airway pressure isn't going crazy. If any of them are going to give you trouble, it's this green line. Sometimes a little bit of condensation will get in there, and it'll cause your mean airway pressure to kind of flip-flop everywhere. Just empty that out or replace it if you're having excessive issues. Also, on the other side of this, there's little holes right here on this circuit. That's where you will dump the additional condensation, and some will go drip down from the diaphragm. Okay, now let's look at buttons. So if we follow our little arrows, we have a silence button, the most important button. It gives us 45 seconds to silence. It will say reset power fail button. This is a very important button, so make sure you always have this one in your viewpoint. So this is what actually manually pressurizes your ventilator. It helps with your initial start. It helps if there's a disconnection and you lose power, if you lose pressure, you hold it down and it will repressurize the ventilator and the circuit so that you can provide the oscillation. So let's say you get disconnected, you're switching out a suction catheter, whatever it may be, just, disconnections do happen. We're all human. And you press the start stop and it won't go. Hold down this power reset button and it will power it back up and start it. The start stop button starts and stops oscillation. It will continuously hold your set mean airway pressure. So what it does is, like for example, we have 10.5 centimeters water pressure. It will just hold it, but it won't have the oscillation happen. We'll use this for listening and assessing, maybe checking for patient effort, various different reasons. Most commonly, it'll be done for assessment to listen to actual lungs and tummy sounds. That's also where I'll start and stop to make sure my piston is centered on my oscillator. So I'll pause it, I'll see that it's lined up right in the center, and then I'll restart it super fast. Over here are some super fun old school 1980s dials that you get to flip up and down. We typically want those are for the mean airway pressure. So you'll keep those 2 above and 2 below your set mean airway pressure. So like for this, I would maybe go 12 to 14-ish because it's 0.5, and then 7, 8-ish for my low. And then we'll just kind of go over a few things. We have our mean airway pressure here, our amplitude, our hertz. I've never not worked or been anywhere that this is inspiratory time. We keep it at 33% to help maintain that 1 to 2 IE ratio. I've never really seen anybody adjust it, to be perfectly honest, because we know how it works with that set I time. Right here, you can see the piston oscillation. And then over here, we have our bias flow, and then our limit and our adjustments. Our FiO2 analyzer, our heater is over on this other side with the humidity. Sorry, you can't see it. Some condensation will drip down into this tube, and then you just empty this with a 60 ml syringe. Just additional condensation. Right here is where I was talking about. You will kind of dump your circuit to let it come out. And then our blender. You do not need to this is a question I get a lot. You do not need to pause the ventilator to suction on the oscillator. You can just go ahead and suction and you will be just fine. Baby will be just fine. Suction while the vent is still oscillating. I like to always preach you keep your emergency equipment close to your heart. So keep a mask somewhere where you know where it is. I like to tape it to my ventilators so that I can just grab it and I know where it is. And then just in case, I keep my little stopper that comes with my circuit. Okay, that's just kind of an overview of high frequency oscillatory ventilation. These are my thank yous to Sensor Medics, to the University of Utah NICU, and of course Artie, who unknowingly will attend all my lectures. Please let me know if you have any questions. The people I'm making this mostly to aim at should be able to get a hold of me either through my email or text me or grab me at work or during class. Either one, whatever works for you guys. Hopefully this was helpful, and thanks for listening, guys.